Hey everybody, it's Dr. May. I'm here with part 2 of my 3-part series about psychogenic non-epileptic seizures, or PNES. And as I mentioned in the first video, I recently did a whole lot of researching about this so we could help one of the clients we have at our facility. And so I learned a bunch of stuff and shared it with the faculty where I work. And I also wanted to share it with you because I feel like it's an important topic, and having more education out there wherever possible is important. So I will share my screen with you for this part 2. All right, so this one is going to focus on making and presenting a diagnosis of PNES. So this video is partly for clinicians or professionals, and also partly for consumers or people suffering from PNES or their family to kind of understand the process a little bit better. So sometimes when I talk, it's going to sound more like I'm gearing it toward one group versus another, but I hope either way you will get enough out of it to help you. All right, so this is the agenda I had for the entire series. So the first part that I did last week covered the first 3 items on this agenda. And today I'm going to focus on number 4, making and presenting the diagnosis. And as part of that, I'm also going to go over a lot of common differences between epilepsy and PNES, just so you could kind of understand some of those differences a little bit better. So in a little bit more detail. All right, so just a quick review, and I did go over this in the first video. So I just want to go over the way they define PNES, or psychogenic non-epileptic seizures. So they're a type of functional neurological disorder, which means that your neurological symptoms are based more on non-biological causes. And it might be an emotional cause, but it may or may not be identified. They're paroxysmal, which means that they just come on suddenly and involuntarily. So people are not doing this on purpose. It just kind of comes out of the blue. They're time limited. They might last a long time, but they're still time limited. And there's alterations in behavior, motor, which is movement, and sensory symptoms. There may be with or without alterations in the level of consciousness. So you might have some awareness or no awareness. And they can look like or mimic an epileptic seizure, but there's no EEG changes associated with them. So going along with that, the gold standard for being able to tell whether your seizure is an epilepsy or PNES is what they call a video EEG. So you have to go to an epilepsy center where they have certain equipment to kind of wire you up to EEG machines and measure your seizure activity while you're having it in the lab. So if you have a seizure, they'll be recording your brain waves at the same time. So this way they'll be able to tell in their lab if what looks like a seizure is actually creating the EEG waves and is epilepsy, or if there's no EEG waves and it's probably PNES or something else medical. So while you're there, it might take 24 to 48 hours or even longer, depending on your situation. And for some people, like I talked about in the previous video, you might have both epilepsy and PNES, although that's less common. And sometimes in the lab, they could see both kinds of seizure activity and can tell the difference between one and the other, or notice that you have both. So when they're monitoring you, if you were already on anti-epileptic drugs or anti-seizure medications, they might taper them off first just to see, because if it's preventing an epileptic event, they want to see if you're having an epileptic event without it. But also, if you're taking it unnecessarily for PNES, you might, in the end, be able to get off of those drugs, which could be a positive thing. And also, because it's videotaped, they could show it to you and your family later, and they could kind of tell, like, does this look like the typical event? Or was this something different that happened in the lab? And that's something they might want to look at as well. If you're not able to do that for one reason or another, the next best option is to get an EEG headset from an epileptologist or a neurologist. And it kind of looks like what that girl has on the left. And you wear that around your house or around your wherever you are operating. And when you have a seizure or you believe you're about to have one, you could press a button and then it records your EEG waves. And then later on, your doctor could review that and see if if it was indicative of epilepsy or not. So, but when you're at home, because you're not being observed, you should stay on your anti-epileptic drugs because they don't want any problems while you're kind of off on your own. So you would probably stay on your medication in this situation. And the next best option, which is, not as good, but still something better than nothing, is if you're living with somebody or some people, they could record your event on their phone and then show that to your doctor. Because sometimes, although it's better to get the brainwaves at the same time, it's still better to have a visual of it just to see if it looks like something typical or atypical, so they can get a better sense of what they're looking at. And you can always follow up with something more afterwards if they want more follow-up. Okay, so this slide, just to give you a little background. So I read a bunch of journal articles where they did studies comparing people with epilepsy versus PNES. And the slide started out very small. And then the more I read, the more things I found. And then it became 2 slides. And so, and there's even more I could have put, but I didn't want to go too overboard. But what they've done is they've done a bunch of studies comparing the 2 conditions and trying to tell different ways to distinguish them. And it seems like because PNES is such a heterogeneous disorder, there's no perfect way to distinguish epilepsy and PNES. And in fact, they said people who are professionals and specialize in seizures, like epileptologists, sometimes just looking at them can't tell the difference. So that's why, if you're only giving a video of your seizures to the doctor, they may or may not really be able to tell. And sometimes they're even surprised. So these are some common differences, but it's not 100%. And sometimes, you can't completely rely on just this stuff. So just to keep that as a disclaimer. All right, but either way, I'm going to go over some of these with you just so you get a better idea. Okay, so the main difference, as I've kind of said before, is that epileptic seizures generally have the EEG abnormalities, and PNES does not. And I said generally for epileptic seizures because once in a while they don't see the EEG changes. And like I mentioned in my previous video, it's partly because it could be deep in the brain or it could be a very small area and it may or may not register very easily on an EEG. Epileptic seizure, another main thing, that epileptic seizures are short lasting, less than 2 minutes. If there's status epilepticus, which is like a series of epileptic seizure activity episodes in a row without a break, it could be 5 minutes or longer. And so therefore it can kind of look like PNES. But an epileptic seizure itself is less than 2 minutes. So that's one of the main distinguishing factors because PNES episodes tend to be much longer, sometimes 5 to 10 minutes, or sometimes several hours. Some people, have had an episode that kind of fluctuates with seizure activity on and off for like 8 hours sometimes. So that's one of the main things that makes it different. Epileptic seizures, often a tongue bite on the side, whereas PNES, there's often no tongue bite, or if it happens, it's on the tip of the tongue. So they say that's one of the main things to look at also. Epileptic seizures, injuries are common, whereas injuries are much more rare for PNES. Another main distinguishing factor is that with epileptic seizures, eyes are often open, whereas PNES, eyes are closed, and it's hard to pry the eyelids open for the person. And epileptic seizures, in terms of the movement, it tends to be in a stereotyped or typical kind of a way. So it evolves with bilateral adduction, which means movement of the limbs toward the midline, and external rotations of the limbs. Then tonic extension of all 4 limbs. So it's kind of a stiffness and they're extending outward. And then diffuse jerking movements. So PNES doesn't always go like that. It could be different order. It could be different limbs doing different things. It's not the same kind of movements at the same time on both sides bilaterally. There could be, but that's what they say, out of phase clonic activity. So it doesn't evolve in a certain order. It could be any kind of order. It could be rhythmic shaking movements and then periods of inactivity and then coming back again. They talk about side to side head movements are common. And also forward pelvic thrusting movements are common. And also dystonic body posturing. So kind of like a stiffness with like a kind of unusual posture could happen as well. But again, it could be very atypical and it's important to show your doctor what it looks like. All right, in terms of vocalizations, they say with epileptic seizures, it's more like noise kind of made in the beginning and then it stops. Whereas in PNES, vocalization could persist throughout the episode, and it could kind of like be different pitch intensities and kind of fluctuate. So that is another thing they noted. Breathing wise, epileptic seizures, people tend to have deep, regular, and loud breathing, and sometimes even snoring. Whereas breathing in PNES episodes are more rapid and shallow and irregular. Okay, slide 2. Are you digging it? Is it cool? A lot of information here, huh? All right, hope I'm not boring you too much. All right, so another important thing, epileptic seizures, people are often not conscious and don't remember it afterwards. PNES, as I mentioned in the definition, there could be with or without alterations in awareness. So you may be somewhat aware during the seizure, or very aware, or not aware at all. And it could depend episode to episode or within the episode. Some people have reported hearing people say, "Oh, come on, get up, you're faking it," during the episode. So it's important to be very respectful if you're around somebody having a PNES episode, because they might be hearing what you're saying. And it can be really hurtful to say negative things to the person, especially implying that it's being faked. Also, during epileptic seizures, people could be aggressive or kind of just out of it, not being their usual self with their behavior. And PNES, people could be emotional or even crying during an episode. And in certain cases, they might kind of relive, almost like in flashback fashion, kind of a traumatic memory during the episode. And as I mentioned in the first video, there's a correlation between history of trauma and PNES. So that's partly why that could happen. There's certain medical things that can happen during epileptic seizures that don't happen during PNES. So those could include tachycardia, which is like a rapid heartbeat, hypertension, which is high blood pressure, hyperthermia, which is like your core body temperature goes down, and cyanosis, which is like a lack of blood flow or oxygen to certain areas of the body, and it looks blue. But that does not happen in PNES. Another interesting and sort of controversial thing is that epileptic seizures are not induced by suggestion or techniques because they're much more medical, whereas because PNES is more emotional, they could be induced by certain suggestions and things such as like compressing a temple region or applying a tuning fork on someone or a moist swab or a saline injection. There's some questions about the ethical nature of these things, but it can induce a PNES episode in some people, but it does not induce epileptic seizures. So it's a pretty good way to tell the difference, but again, it's questionable ethics to do that. So then after the seizures, people with epilepsy are often confused for several minutes or even hours and don't remember the event. Because again, like they don't really have consciousness during the event, and then afterwards they may not. They usually don't remember the event. For PNES, there could be some confusion afterwards, or you may just not feel right, may not feel like yourself. Anecdotally, people report, they could feel sick or have a headache or other kinds of things afterwards, and they may or may not remember the event. Epileptic seizure, people with epilepsy generally don't have pain conditions, whereas it's much more common with people with PNES, such as fibromyalgia or headaches. Psychiatric comorbidities or co-occurring psychiatric conditions are less common with epilepsy and much more common with PNES. So the most typical ones, as I discussed in my previous video, are anxiety, depression, PTSD, and personality disorders. And finally, epileptic seizures tend to get better with anti-seizure medications, at least in a decent portion of people, not everybody. And PNES seizures do not get better with anti-seizure medications. However, certain anti-epileptic drugs can help underlying mood lability, which might be contributing to the seizures. So if that's the case, if the mood lability is treated with anti-epileptic drugs such as Lamictal, it might reduce the PNES episodes because you're treating the underlying mood that's fueling the episodes. But that has to be really something that's carefully assessed by your doctor to determine if that's appropriate or not. Okay, so just to give you also a sense of the heterogeneity of the disorder, Just like certain psychiatric conditions have subtypes, such as for ADHD, there's hyperactive ADHD, there's inattentive ADHD, there's a mixed type. With bipolar disorder, there's manic type, there's depressed type, so there's different types within a disorder. So with PNES, there's different people that have proposed different classifications. So I put 3 versions of those on the bottom, but there's probably about 10 or so different, groups of people that came up with these different groups of classifications. And so just to give you a sense that the presentation could fit different categories. And so that's partly why the brain activity is different, like we talked about in the first video. So for example, one group said there's hypermotor type, so it's like maybe a lot of motor activity. There's an akinetic type with maybe very little motor activity, a focal motor type, and PNES with subjective symptoms, so people reporting certain symptoms. Some types were dialeptic coma-like ones, where it's like very reduced awareness. You're kind of almost like comatose in a way in your presentation. So there's different kinds of style. I don't want to go to every single one, but just to get a sense that like your presentation could be one of these things, or maybe a few. Okay, so let's say you went to the epileptologist or neurologist, they assessed your situation, maybe you did, the video EEG, and now they want to speak to you about what's going on. So if you're the doctor, it's very important to remember that you could be changing the person's whole life by giving them this diagnosis. Somebody might have sworn that they had epilepsy for a long, long time, and now you're going to completely shift the way they see themselves, because now all of a sudden it's like, you don't have epilepsy, you have something else. And accepting that can be a challenge. And also the fact that emotions or trauma can fuel it can be a challenge for somebody to accept. For some people more than others, for sure. So when you speak to your client, it's important to present it in a careful and compassionate way, understanding that it could be hard to hear, and to explain it very carefully and provide information such as pamphlets and maybe written materials or websites that could help, and so forth, so that the person can better understand their diagnosis, show the person you're working with them, that you're giving the proper referrals if needed, and really following up. So I heard one doctor say, don't diagnose and adios. Don't just say, guess what, you have PNES, you don't need me, you don't need your anti-epileptic drugs, good luck, and that's the end. It's not really fair, because the person still needs treatment, but it's important to show, what they need and explain why. Okay, so a little repetition of what I said here. So you let the person know they don't have epilepsy. You show them the EEGs, and maybe their EEGs compare it to the kind of EEGs that a person would have if they had epilepsy, just so the person can get the visual of what their brain is doing versus what the brain of an epileptic person is doing. And kind of engage the person into how perhaps, their emotional situation or their psychiatric problems or history of trauma could be fueling this situation, which is the case for a lot of people, although not 100%. And so see how the person responds and then take it from there. And it's also important to get the family involved, especially if the person's living with their family, because having that family support and understanding could be really helpful in terms of the course of treatment. Because if the person with the seizures understands it, but the family does not, and they're not supportive, it just creates extra stress for the person and makes recovery that much harder. If the person does not accept the diagnosis, they might need more time. Maybe they need to have more information first. Maybe if they read up a little bit more, they could begin to accept it. Other times they might feel more comfortable if you did additional follow-up testing, such as neuropsych testing, but it really depends on the person. But just like any diagnosis, sometimes it takes a while to digest it. And so don't give up, just keep working with the client. Okay, so once your diagnosis of PNES is made, what do you do now? Where do you go from here with treatment? So stay tuned for my part 3 video to find out more about that. Okay, so I hope this was informative and helpful for you, and I look forward to seeing you in part 3. All right. Thanks, everybody. Take care now.